I'd like to call Dr. Richard Vaughtry to present the report on behalf of general practitioners. Richard.
Thank you, Chair. RB. Just a few weeks ago, the Nuffield Trust reported that the number of GPs relative to the size of the population had fallen in the most sustained way since the 1960s. And this followed the previous report that showed that rather than expanding the workforce with an additional 5,000 GPs, the government has gone backwards, and we now have a shameful projected gap of 7,000 GPs needed. The King's Fund and the Nuffield Trust could not have put it clearer when they said, unless action is taken, shortages on this scale represent a fundamental threat to the sustainability of primary care. Do you know what? That's absolutely right. After over a decade of chronic underinvestment and spiralling workload pressures, it's no wonder that the crisis in general practice is making headline news, with the BBC devoting a whole day to the reporting from GP surgeries up and down the country, telling the story about what it's like for GPs, their staff and their patients each and every day. But at long last, governments are now starting to listen to us and working with us to start to tackle the crisis that is of their making. In Scotland, government made general practice a priority, and this led to the major contract changes last year, which were now being implemented, building around the expert generalist GP and their team, maintaining practices at the heart of their communities and supported by local health board services. In Northern Ireland, even after 2 years without a government or health minister, GP-led federations are supporting practices through workforce expansion and leading the way with a pharmacist in every practice. In Wales, difficult negotiations have concluded this week, with new investment being made and health boards tasked to reduce the risks to partners in struggling practices. And in England, we now have an NHS First commitment to £2.8 billion for general practice over the next 5 years, which crucially builds on our core contracts and retains our independent contractor status. The GP Partnership Review commissioned both by Government and NHS England clearly showed how our model of working embeds us in the communities for the long term, when other services come and go, how it gives GPs the freedom to advocate for our patients, enable us to innovate and respond quickly to change, and most of all, delivers continuity of care, which saves people's lives. When properly supported, it's good not just for GP partners, but for salaried and locum GPs too, as well as for the extended team who work with us. And that's why in England, we will root our primary care networks in our communities, why local GPs will lead them, and why, unlike remote, virtual, anonymous, digital-first organisations like GP at Hand, we will maintain our vital connection to all people for the long term, no matter what health needs they have. Let me be clear. We will not just direct our services at the affluent few. We are here for every patient. Across the UK, we have recognised that GPs and patients will benefit from an expanded healthcare team, working alongside us, directly based in our practices. In England, over 99% of practices have now formed and joined their primary care network, which will deliver recurrent funding to support recruitment of over 20,000 additional people to work with us. It means a pharmacist in every practice, not only reducing GP workload, but also improving the quality of care. It will mean connecting patients with physiotherapists directly, rather than having to wait for months for a referral. And it means social prescribers, helping to meet the needs of those who are lonely and connecting them with others in the community. By doing this and more, we are not only starting to tackle dangerous workload levels, but we will also be enabling GPs to focus more time on those who need us most. But with an expanded team, the risks of indemnity increase. For GPs, indemnity payments had become unsustainable, and this year, in England and Wales, we have finally been able to tackle this. So for every NHS GP, partner, salaried GP or locum, working in hours or out of hours, once and for all, we have taken away the burden of So our contract agreement in England retains our independent contractor status, delivers an expanded workforce to reduce GP workload, reconnects us with our community team, removes the burden of indemnity and focuses on good quality improvement. We've listened, we've acted and we have delivered. We've achieved a lot this year, but we are far from complacent, and there is much more that needs to do, not least within the BMA itself, which is why I'm pleased that the BMA quickly responded to the concerns raised by female GPs about inappropriate behaviour, and why I'm committed to work with the review by Daphne Romney so that lessons are learnt, action is taken to ensure that everyone feels respected, listened to, and can fully engage in our vitally important work. The work of GPC UK needs for all of us to be involved to succeed. In Scotland, the agreed premises loan scheme has got underway and even been invested in further as it's been taken up by so many practices. But in England, as our survey showed, the problems caused by premises remain a massive issue, with only half of practice premises being suitable for current needs and 80% of GPs saying that their premises could not cope with the future needs of their population growth. We cannot respond to the growing needs of our patients and the expanding multidisciplinary workforce if we don't have practice premises fit for the future, and government must act. There are also practices leasing their premises from the NHS that face another problem. For years now, some practices have faced astronomical rises in service charges, some seeing theirs more than double, often for services that they've not asked for and do not receive. This is unacceptable and cannot be allowed to continue. And so I can tell you today that the BMA has sent a letter of claim to NHS Property Services, and if they do not give us an acceptable response, we intend to take them to court and we intend to win. In England, we continue to be blighted by the failures of PCSE, a body that's supposed to offer support, but the reality is failure after failure, the latest being a failure to deliver 160,000 patient records to practices. And whilst we've managed to sort out many of these problems and get some of the basic systems back on track this year, we've seen one of the worst failings of all, with them not sending out over 43,000 invitations for smear checks, and worse, not informing 4,500 women of their results, potentially leaving some of them at risk. And then, rather than sorting all of this out, NHS England have the audacity to suggest that practices should be investigated by the Counter-Fraud Service. This anti-GP rhetoric to distract their failure is completely unacceptable. NHS England has at last said it will take the cervical smear service back in-house, but it must do more. It must end the private contract with Capita and return this vital service for general practice where it belongs, in and run by the NHS. And while this failure goes on, the wider failures left for many GPs leave them in pension limbo, with no confidence that payments have been recorded and processed properly, and often delayed, or no statements to confirm what's been done, so leaving GPs at risk of additional and punitive tax payments over which they have no control. This shambolic situation cannot be allowed to continue. GPs, like other doctors, are being forced to reduce sessions or even leave altogether simply because of the damaging pension rules. The impact of annual allowance, lifetime allowance, tapering, annualisation, scandalous scheme-pays rates and the failure to award death-in-service benefits to locum GPs are all impacting recruitment and retention. At long last, we are attracting greater numbers of GP trainees, but we will continue to lose more GPs than we gain until the government listens and acts on the serious impact of pensions. We could not achieve what we've done this year without the support of our expert staff and our 4 negotiating teams in Belfast, Cardiff, Edinburgh and London, and I want to thank them all. We've also depended on the expertise of our policy leads, many of whom have reached the end of their term of office this year, as has Zoe Norris, our Sessional GP Committee Chair, and Charlotte Jones, Chair of GPC Wales. We owe them all a huge debt, and thanks to all of them. This year, working together, we have achieved a lot, but there is much more to do. And so we will continue to fight for the general practice that both doctors and patients deserve. Thank you very much.